this is the last set of slides for resistance training. We've covered quite a lot about it. Just some last things I want to kind of go over is, the determinants of it. So when we're thinking about applying an exercise prescription of resistance training, we need to think of a number of things. And I've already alluded to quite a few of them. Just the last couple of things I need to add in. So when we're looking at creating or designing a resistance exercise program, one of the key principles we can think of is called the FIT principle. The frequency of the program, the intensity, the time, and the type. These are the things I want us to kind of think about. So when we look at frequency, obviously we're looking at how frequent we have to have it. We're looking at how intense it has to be in terms of what kind of resistance we're giving. The time, so how many times they're going to do it or for how long they're going to do it. And the type, and it could be strength or power or endurance. When we're giving this, something we have to think about is when we're setting up these exercises, it's not just about giving a picture to someone and say, please do this or do that, and it's going to help you a lot. There's a couple of things you have to think about. The first is, if you're going to identify a structure or structures that require strength training, then the patient needs to be sort of trained into how to isolate that muscle and make sure that that muscle that you've identified is getting the proper training that you've decided that it needs. So when we look at something called proper alignment, what we're looking at is, you think of the muscle that you want to train. What is its fiber orientation? What is its line of pull when it does its specific action? And through that, then we start to think about the exercise that we want it to do. It's exactly the same as muscle testing, where we try to get down to an individual muscle working by itself without any substitute motions to try to test just that one particular muscle to see how strong it is. We would be using very similar positions to actually strength train that muscle. The next thing is stabilization. Obviously, the one thing that's important is through stabilization, whether that's a stabilization of a joint or the whole body in general, stabilization ensures correct muscle action, the one you've identified, the one you want it to do, and a correct movement pattern that avoids what's called substitute motions, which I've mentioned before. So the moment that you see a patient performing an exercise, and you note that there's other motions going on, those are the ones that you have to try to get rid of and speak with the patient about stabilizing and holding body segments or body shapes to avoid those sort of movement patterns that are substitute motions. We've identified the structure that we want to apply a strength exercise program to. We want that particular target muscle or muscles doing the work, not other ones. There are a couple of different ways we have stabilization. The first is external stabilization, which could be you. So when we looked at manual resistance training, and we talked about you as the therapist being the resistance in the early days, this is external stabilization, is you putting your hand on a joint or proximal to a joint, stabilizing the body, maybe while it's sitting at a chair, on the table, or even lying on the table. And they do go through the motions, whether it's through your resistance, rubber tubing, or whatever it might be. The other thing that's an external stabilization could be straps or belts. So sometimes we have someone who's relatively compromised post-stroke and the core can't stabilize. We may be actually strapping them to a chair or on a table. The other type of stabilization is probably the one you're most commonly aware of, and that's internal stabilization. And this is through isometric contractions that's holding either joints or body in particular postures or positions. So we say here it's achieved by an isometric contraction of an adjacent muscle group that does not impact the desired movement pattern. So, quite often when you're looking at exercises on TV, or you're listening to an instructor at a class, they talk about engaging the core before you begin the movements. This is a form of stabilization, for example, that helps prevent substitute motions from happening when the exercise is being done. The other thing we have to look at is intensity. So this is the amount of external resistance imposed on the contracting muscle during each repetition of the exercise. So the one thing we have to remember is this overload principle. We need to stress this tissue out to make it adapt. So we have to think about, without getting too much stress on the muscle, we still have to achieve some stress to get the adaptive changes. So this is where we start to think about maximal versus submaximal loads. Now, what do I give? How do I ensure that I'm getting a good adaptive reaction without doing any kind of injury or making them work too hard? Well, the first thing in terms of deciding whether it's submaximal or maximal goes all the way back to, things I've said a couple times now. This is the goals and expected functional outcomes of the program. So through your case history evaluation, through your assessment, through your interview with your patient, you come to the conclusion of what needs to be done here to perform a task or to prevent injury in another pathological condition. So this is really going to determine what it is you're after. And then we look at a task they have to do. Does it require strength? Does it require power? Does it require endurance? These are the things that are going to involve that. I think I've alluded to it a little bit in the last set of lectures. If the job of a patient requires them to move 5 pounds and all they can produce is 5 pounds, they're working at 100% of their max. This leads to injury and it leads to exhaustion. So if I can train that individual to do 10 pounds, now when they do their 5 pound task, it's only 50% and they'll feel it's much easier and there's less chance of injury. Determination of load, as I said, is dependent on the goals and expected functional outcomes. The cause and extent of muscle performance deficits and the stage of healing also influence intensity. So where are they at in the stage of healing? How much damage or problem is there with contracting muscle you want to work? The other thing we have to think about in intensity is the age of the patient, their general health, and their fitness level when they're starting out in this program. Obviously, if they've been relatively sedentary for a large part of their life, and you're starting on a program due to an issue, you're going to start with a very low intensity to work them through. The level of resistance is lower in rehab programs as compared to conditioning programs for healthy individuals. So usually we have something that's relatively compromised when a patient comes to see us for a resistance rehab program or other stuff. And so we generally tend to start fairly low. If you remember from, I think, the second set of slides, usually in rehab programs, we start endurance training before we ever get to strength training to ensure that there's less likelihood of injury and so forth. The thing to always remember that if exercises which cause pain indicate that the intensity is too great, then we have to back off. So one of the things we need to look at, and this is why we need to see our patient relatively consistently, if they come in and they say, last week I did these exercises and it caused nothing but pain and discomfort, then obviously we've got too much intensity here and we need to back it off just a bit. The next thing we have to think about is the volume. So volume is a summation of the total number of repetitions and the sets of a particular exercise during a single exercise session multiplied by the intensity of the exercise. So what does this mean? Volume is represented as to how many times you want to do the exercise. 5 times in a row, 6 times in a row, 7, 8, 9, 10 times in a row. How many times do they do that 8 times? Maybe it's one set of the 8. Maybe it's 2, maybe it's 3. And then all of this is influenced by how much weight they're lifting or how much resistance you're giving them to perform the task. So you have to consider what's the intensity of the exercise, so how much weight are they doing, and then you have to figure out how many repetitions you want them to do and how many times you want them to do that repetition. As a general rule, the higher the intensity or external resistance, the lower number of repetitions and sets. So if you want pure strength training using high weights, those repetitions make it down to between 4 and 8, and maybe you're only doing 1 or 2 sets. Conversely, the lower resistance, the higher number of repetitions and sets. So if you're going for an endurance type of thing where the weight's quite consistently lower, then maybe you're doing 10 to 12 repetitions and maybe you're doing 3 or 4 sets. Remember that a repetition is the number of times a particular movement is performed consecutively, and a set is a predetermined number of consecutive repetitions grouped together as a set of exercise. The thing to always remember is that there's rest between your sets. And if you remember from a couple of slide packs ago, I talked about muscle recovery, which is 3 to 4 minutes, with the first minute being the most amount of recovery. Hence the reason why when I work out, I tend to watch my watch and I start my next set after about a minute of recovery time. Periodization. So periodization refers broadly to training that is structured around periods of progressively loaded training stress followed by rest. So this is where we're sort of stressing the body, but we're giving it recovery time so that it can function, the patient's body can function at an optimum level in order to do the exercise. So theory points out the three phases of the body undergoes when experiencing a new stimulus. So when you are putting them on a new weight program, the first phase is alarm, then resistance, and then exhaustion. So for example, in the alarm state, this is the initial shock of the stimulus. This is where we end up with a delayed onset of muscle soreness because maybe they're doing it for the first time. You are always going to get a bit of DOMS no matter how light you're doing this because this is the alarm phase. After the alarm phase, when we go into the resistance phase, the alarm phase has alarmed the system. It's starting to adapt, and this is why we don't get the same pain anymore. So resistance is the adaptation to the stimulus. This is where we begin to get better at handling the workload and progress in a program. Exhaustion is when there's overstimulation. So overtraining or overreaching is a decrease of muscle strength and exhaustion. What we're after in periodization is that we want to remain in the resistance stage. In this stage, the body performs optimally or closer to it. So there's an initial alarm, and we want to maintain resistance. If we find our patient is constantly fatigued or saying that they're exhausted, discomfort, our intensity level is far too high too quickly, so we want to back off and we take a period of time. When we look at periodization, the traditional sense of it, there are various cycles within that. So we have a macro cycle that is what we want to look at for the year, a mesocycle, which is weeks to months, and then a microcycle is work per workout, per day, or weekly. So if you're doing periodization, you may have an end goal of a year, but you break it all down into smaller compartments of working through, remembering that you want to get through that alarm phase and get to the resistance and avoid exhaustion. What I just looked at was described, this form of periodization is described as a training plan that gradually increases intensity and decreases volume throughout multiple mesocycles in an annual training plan. So here's the key thing. As you're gradually increasing the tension or the resistance that you're giving the patient to do, right, and you decrease the volume throughout the cycle. So you start off at a particular weight, at a certain amount of exercise reps and sets. As you continue through your cycles and the weight gets heavier and heavier, then you decrease the volume. Maybe initially you have them doing a couple times a week, and maybe they're just doing that exercise once a week or once every 2 weeks, depending on what's going on. Through the gradual increase in variation that you're doing, you maintain optimum levels of energy and reduce the potential for injury. If you really want to get into this, it's not part of this program. Again, for those who may have taken health and fitness promotion or those who did kinesiology, this all makes sense to you. But if this is new and you're interested in something like this, there's lots of places you can go for training. You can come and speak to me about it, and I'll show you a couple areas you can work in. Integration of function. I have nothing written here because I have talked about this pretty exhaustively. You always want to integrate functional movements in the resistance plan. So of course, as we've said before, between your assessment, between your interview, you get a sense of the goals of your patient, and you know what it is they need to do. So you start to view it. What angles do they need to be in? What postures do they need to be in? How much weight do they or don't they have to move in the context of the task that they're doing? Remembering if that could be at home, could be play, or could be at work. But you must integrate function into the workouts so that they're prepared to do the task that you're trying to get them towards. Okay, the last thing is something called open chain and closed chain. So this might be new to some of you and not to others. When we look at this as a bit of a philosophy, this has to do with movement in the realm of the body and outside the body. When we look at open chain, this applies to completely unrestricted movement in the space of a peripheral segment of the body, such as waving your hand or leg in the air. A closed chain movement has the peripheral segments meeting with resistance, so remains fixed with the resultant proximal segment moving over the distal. A prime example is a push-up, and I'm going to be showing you some pictures and whatnot here in a minute. So open chain. The distal segment, such as the leg or foot, the hand or foot, is free to move in space. Think of throwing a baseball. Think of kicking a soccer ball. Those are all open chain exercises. The limb movement only occurs distal to the moving joint, and muscle activation occurs in the muscles that cross the moving joint, such as an arm curl, where the hand moves caused by the biceps brachii. These are usually performed in non-weight bearing positions. The load is applied to the moving distal segment. So we can see here, because the arm is moving in the leg and they're open, this is considered an open chain exercise. It's used quite a lot for core work. Puts a lot of stress in the mid-core of the body. But because the legs and the arm is what's moving here in space, this is an open chain exercise. This is another exercise that's open chain that we can see here that helps, again, stabilize the core and work the upper back muscles and those that are periscapular in relationship to the shoulder. And again, they're open chain because the hands are open out to space and are moving out in that space. Closed chain exercise are motions in which the body moves on a distal segment that is fixed or stabilized on a support surface. Movement at one joint causes simultaneous motions at distal as well as proximal joints in a relatively predictable manner, such as push-up with the body raising and lowering at the shoulders with movement at the wrist and elbow. These are performed in weight-bearing positions. So we see here, this is some variations of closed pack where we can see the body is being loaded on the arm. The arm is not moving. It is the core that's moving, doing the majority of movements with some minor movements at the wrist and elbows. Here as well, we see the same idea. This is all with arms, but here's an example of a closed pack position of legs, because it's the center of the body that's moving on these fixed legs. Even though they seem to be extended out on the ball, it's this core that's doing the work, so therefore it's considered to be closed chain. And you'll get into a bit more of this as you move through in terms of open and closed chain things are decided based upon, again, what the patient may be bringing to you. Obviously, if you've got a pitcher, a baseball pitcher or a baseball player that throws, you're looking at open chain exercises to mimic the motions. You might also be using closed chain exercises to tighten the core and make it stronger. You've got someone who sits and does work. You may be that you're doing closed chain exercises for that. So this is all part and parcel of how you individualize for your patients and your patients' needs and goals with resistance training. Thanks for this. It's been great. That's the end of resistance training and stretching and PNF. So after this, we'll be going back to muscle physiology to talk a little bit more about contractions and so forth. And then we'll be done the course. Thanks for listening.